Okay, we can start. Good morning, ladies and gentlemen. We are now getting started the second half day of this meeting. Yesterday, we have listened the news about the pathophysiology and the medical treatment of diverticular disease, and in particular of symptomatic and complicated diverticular disease and acute diverticulitis. Today we have another half-day session, in which we will listening the news about the diagnosis of the disease and about the surgical treatment of the disease. We have two sessions. The first session has four chairs, an interesting quartet: Professor Brandimarte, Professor Graziani, Faggiani, and Professor Gerardo Nardone. And the second session, the surgical session, will have as chairman Professor Papagrigoridis from Athens and Dr. Marcello Picchio. At the end of the second session of today, we will have a brief discussion about the future of the diverticular disease and the hypothesis to construct altogether the new International Diverticular Association. So I leave the floor now to the chairs of the first session of today, and then to Dr. Brandimarte, Graziani, Faggiani, and Nardone. Please.
Good morning. We can start for the first session, diagnosis, and I give the floor now to Roberto Faggiani to introduce the first speaker.
Good morning, and for the first presentation, Dr. Walter Risei with biomarkers.
Thank you, Mr. Chairman, dear colleagues. Good morning. I am Walter Risei, and today I would like to speak about the role of biomarkers in the diagnosis of diverticular disease. First of all, talking about the natural history of diverticular disease, we know that most people with colonic diverticulosis remain asymptomatic. About 20% develop symptoms, and about 10 to 25% will present an episode of acute diverticulitis. We know that acute diverticulitis is the main inflammatory complication of diverticular disease. In this scenario, the inflammation of diverticula may be a key point for the appearance of symptoms and development of complications. And for these reasons, the diagnosis of diverticular disease should be correct, excluding other causes of abdominal pain, early as far as possible to prevent or identify severe complications. The current diagnosis of gastrointestinal disease in general and also in the diverticular disease is an integrated process based on clinical assessments, symptoms and signs, laboratory tests, and instrumental assessments. Do we have biomarkers to manage diverticular disease? Yes, we have serological and fecal biomarkers. Talking about fecal biomarkers, calprotectin is a protein that represents about 50 to 60% of neutrophilic cytosolic protein. It is released from cells during cell activation, cell recruitment, for example during inflammation or death. It is stable in feces for several days after excretion. In this study, we evaluated the expression of fecal calprotectin in healthy subjects, in IBS patients, and in different clinical settings of diverticular disease. This study shows us that, first, no significant difference was found in fecal calprotectin levels between healthy control, IBS patients, and in patients affected by diverticulosis of the colon. Second, higher fecal calprotectin values in acute uncomplicated diverticulitis and symptomatic uncomplicated diverticulitis disease patients than in healthy control IBS and in patients affected by diverticulosis of the colon. Finally, fecal calprotectin decreased after treatment to normal values in both acute uncomplicated diverticulitis and symptomatic uncomplicated diverticular disease patients. Fecal calprotectin is also able to predict the recurrence of colonic diverticulitis. This is a prospective cohort study that was performed on patients suffering from acute uncomplicated diverticulitis, diagnosed by CT scan. After remission and during the follow-up, fecal calprotectin was analyzed. The study shows that the diverticulitis recurrence was strictly related to the presence of abnormal fecal calprotectin test during the follow-up. DICA classification is a new endoscopic classification of the diverticular disease. In this classification, the severity of the disease is divided into 3 degrees. DICA 3 is the more severe degree of the classification. This is the data of the fecal calprotectin related findings, not yet published, in a recent prospective study. At the beginning of the study, each patient was classified according to the DICA endoscopic score. DICA 3 is the more severe form of diverticular disease. In these patients, the expression of fecal calprotectin was significantly related to the DICA score. Moreover, the expression of fecal calprotectin was significantly related to symptoms. As you can see, the expression of fecal calprotectin was significantly higher in symptomatic than in asymptomatic patients. In this study, we compare the expression of some serological biomarkers in complicated and uncomplicated diverticulitis. All these biomarkers, white blood cells, SR, CRP, fibrinogen, and so on, are useful in distinguishing between acute and complicated diverticulitis and acute complicated diverticulitis. But, as in IBD, C-reactive protein seems to be the most effective marker of histological and clinical severity of the disease. This study shows us that C-reactive protein greater than 50 mg per liter is an independent factor in the diagnosis of acute uncomplicated diverticulitis. Moreover, these authors found that association of clinical symptoms like recurrent left lower quadrant pain, aggravation of pain on movement, the absence of vomiting, age greater than 15 years, and C-reactive protein greater than 50 mg per liter are independent predictors of acute diverticulitis. C-reactive protein seems to be also the stronger marker correlated with histological severity in acute and complicated diverticulitis, with high sensitivity and specificity. C-reactive protein is also correlated with the risk of complications, like a perforation of the colonic wall. About these 2 studies regarding patients with a CT diagnosis of acute diverticulitis, we can see that, first, C-reactive protein lower than 15 mg per liter suggested a perforation to be unlikely. Second, C-reactive protein values greater than 150 mg per liter have an increased risk of complicated diverticulitis. And in those patients, CT examination should always be carried out. Finally, in patients affected by acute diverticulitis diagnosed by CT scan, they found that only CRP was significantly correlated with the risk of perforation for C-reactive protein higher than 200 mg per liter. C-reactive protein seems also to be the best marker to assess response to therapy. In this clinical trial assessing the role of antibiotics in obtaining remission in acute and complicated diverticulitis, they found that serial decrease of the C-reactive protein was correlated with the resolution of the left lower quadrant tenderness by day 6 of treatment. The predictive assessment of complicated diverticulitis is a new score, PACO-D score, that was applied to the retrospective cohort and then validated prospectively in a cohort including 282 patients. It included 6 variables: bile sex, constipation, hemoglobin lower than 11 grams per deciliter, C-reactive protein greater than 80 milligrams per liter, severe obesity, and no proton pump inhibitor treatment. That in a multivariate analysis were independently associated with complicated acute diverticulitis. The score classified patients into 3 risk classes for complicated acute diverticulitis. The PACO-D score could be a clinical tool to identify patients at highest risk for complicated acute diverticulitis. What are the innovations in the field of biomarkers? The aim of this recent prospective observational study was to evaluate if procalcitonin could differentiate between complicated and uncomplicated cases of diverticulitis compared to the gold standard. The gold standard is abdominal CT scan. This study shows that at admission, day 1, procalcitonin was significantly higher in patients with complicated diverticulitis compared to patients with uncomplicated diverticulitis. CRP and leukocyte count of complicated and uncomplicated diverticulitis were not significantly different at the time of admission. Moreover, procalcitonin was able to differentiate with high sensitivity and specificity between complicated and uncomplicated cases of diverticulitis when combined with abdominal CT scan. As most clinicians still treat complicated diverticulitis with antibiotics, procalcitonin could be an interesting parameter for guiding therapy and in decreasing antibiotic usage. To conclude, talking about the fecal calprotectin seems to be a non-invasive sensitive marker of diverticular disease severity. In particular, fecal calprotectin may show slightly increased values in symptomatic and complicated diverticular disease, and as expected, shows higher values in acute and complicated diverticulitis. Fecal calprotectin is significantly related with inflammatory infiltrate in symptomatic and complicated diverticular disease and in acute and complicated diverticulitis. Fecal calprotectin is related to endoscopic severity of the diverticular disease. And finally, fecal calprotectin seems to be useful also in monitoring the therapeutic response in diverticular disease. In fact, fecal calprotectin values decreased significantly in patients responding to therapy, whereas they persisted to increase in patients who failed to obtain remission. Talking about the C-reactive protein, the C-reactive protein seems to be the most effective serological marker of histological and clinical severity of the disease, especially in the management of acute diverticulitis. In particular, CRP greater or equal to 50 mg per liter suggests an acute and complicated diverticulitis, whereas CRP higher than 200 mg per liter is a strong indicator of diverticular disease complicated by perforation. CRP seems also to be the best marker to assess response to therapy in acute diverticulitis, and when correlated to other parameters is to able to identify complicated forms of diverticulitis, PACO D-score. Finally, procalcitonin was able to differentiate with an higher sensitivity and specificity between complicated and uncomplicated cases of diverticulitis at admission. Thank you for the attention.
Thank you. Thank you, Walter, for your nice presentation. Before to start with the next speaker, I want to inform you that the discussion will be done at the end of the session. And now it's a pleasure for me to introduce Giovanni Macconi, Professor Giovanni Macconi from Milan. Giovanni?
Hi, everybody. It's a very pleasure to be here with you in this very interesting meeting. And in particular, I thank a special session on the diverticular disease in the colon diverticulitis. Now I ask the director to send my presentation. Good morning, everybody. At first, I would like to thank Antonio Tursi and the scientific committee for their kind invitation in this great international symposium to show you an update on the role of intestinal ultrasound in diverticular disease of the. In this presentation, I will show you something about the usefulness of ultrasound in the detection of acute diverticulitis and its complications, in monitoring acute diverticulitis and assessing symptomatic and complicated diverticular disease. So let's start with the detection of acute diverticulitis. To show you the usefulness of ultrasound in detecting acute diverticulitis, I would like first to start with a simple case. This is the case of a colleague who, time ago, came to my attention complaining abdominal pain, which started early in the morning and became quickly so acute to ask advice. The abdominal pain was in the left flank, without fever, and not associated with the recent changes in bowel movements. My colleague was overweight, suffered from arterial hypertension, and he had never had abdominal pain or other gastrointestinal problems in the past. On physical examination, I revealed a quite localized abdominal pain in the left side on palpation, but without clear signs of acute abdomen. As usually, I work with my sonographic machine in my ambulatory, and I tried, despite the overweight of my friends, to perform an ultrasound scan. And these are the main findings. I found mesenteric hypertrophy here, and the thickening of the bowel wall of the sigmoid colon. And exactly in the site where abdominal pain was greater at compression, I found an hypoechoic outpouching here of the sigmoid colon. The clinical suspicion of acute diverticulitis was quickly confirmed by ultrasound, and in addition, with ultrasound, I didn't show any sign of a complication of diverticulitis. Well, we know that ultrasound is able to detect acute diverticulitis of the colon, particularly in the sigmoid colon. It appears as a focally thickened and dark hypoechoic bowel walls surrounded by a colonic outpouching here that includes a hyperechoic lesion with posterior shadowing, like here. That means usually a fecolite. This lesion is usually clearly visible as it is surrounded by hyperechoic mesenteric hypertrophy. Noteworthy, these findings is usually appreciable where the maximum is the pain evoked with the compression performed with a sonographic probe. To summarize the usual sonographic findings in patients with acute diverticulitis, we found a thickening of the bowel wall, the pericolic fat changes, like you can see here, and also here, and the diverticulum, of course, here and here, and sometimes also pericolic abscess, like a small lesion here. But one of the most findings is a pericolic fat changes that usually means an acute inflammation of the colon. The data of the literature of more than 10 years ago, like those included in this meta-analysis, have already shown that ultrasound is highly sensitive and specific in detecting acute diverticulitis, with the sensitivity and specificity that is quite comparable to that of computer tomography. However, we well know that computer tomography has a wide panoramic view and is more likely to identify alternative diagnosis in patients with abdominal symptoms. A controversial issue on the use of ultrasound in acute diverticulitis is the need of an experienced examiner, which is useful but not mandatory. In this study, the diagnostic accuracy of ultrasound of expert and less expert examiners has been compared. As you can see, the difference in sensitivity to detect the diverticulitis between non-supervised residents who have already performed more than 500 exams and supervised residents with less than 500 exams is substantial, more than 80% the former and less than 60% the latter. However, looking at the positive predictive value, it seems that there are different results. In fact, we can see here that the positive predictive value between expert and less expert examiner is nearly the same. This means that to have an expert sonographer makes a difference, of course, but also that you can try to perform the exam also with non-expert examinators, and that if you can see an acute diverticulitis, this is unlikely a false positive result. In such a way, the sonographic confirmation of clinical hypothesis of acute diverticulitis is useful just to avoid a further examination like a CT scan in most of our patients. That, of course, CT scans should be performed in cases of negative or inconclusive results. Anyway, also taking into account the limitation of intestinal ultrasound, European scientific guidelines and consensus conferences recommended intestinal ultrasound as an accurate technique to detect acute diverticulitis and its complication, and preferably performed by an expert examiner. In particular, they recommended its use as a first diagnostic tool in clinical suspicion of acute diverticulitis and followed by a CT scan in uncertain or complicated disease. The second point that we have to analyze is the role of ultrasound in assessing complications of acute diverticulitis. As you know, the severity of acute diverticulitis can be assessed by means of a Hinch classification. This classification can be useful to predict the risk of recurrence of patients with acute diverticulitis. And as I show in the study, most patients with acute diverticulitis, and nearly 80% we observe in our clinical practice, have a mild acute diverticulitis, an inch 0 or inch 1. And the definition of the severity is very useful, as it may have implications on the risk of further relapses and surgery, and might guide our prophylactic treatment. In fact, we know now that not only uncomplicated diverticulitis, but also diverticulitis complicated by abscesses or small perforations can be managed long term without surgery. As you can see in this video clip, ultrasound is able to assess not only uncomplicated but also, of course, a complicated diverticulitis, in particular situation like this that is complicated by perforation, peritonitis, and large collections in the abdomen. CT scan, of course, offers a more panoramic view of the abdomen and a clearer demarcation of abscesses thanks to the use of contrast agents. But today, even ultrasound coupled with intravenous contrast agents, like you can see in these videos, can assess appropriately and discriminate between phlegmons and abscesses, and can evaluate the size, of course, of this collection and also the feasibility of a percutaneous drainage. In this video, as you can see in your right side here, it is possible to assess fluid collection not perfused with a contrast agent and have the possibility to drain this without the use of a CT scan. The usefulness of contrast-enhanced ultrasound in assessing abscesses has been well demonstrated in this study, where the 57 masses, abdominal masses, were investigated with the SEERS and other techniques. In this study, the SEERS showed to be accurate and can discriminate intra-abdominal phlegmons and abscesses, and may be used, the conclusion, to avoid a technique that can use radiation, ionizing radiation. The possibility to assess diverticulitis and its complications with ultrasound offers a valuable tool to monitor safely and not invasively the patients with their attacks. In fact, in the study mentioned before, the risk of recurrence and operation in acute diverticulitis depends on the severity of the first attack. It is lower for uncomplicated diverticulitis, as you can see here, in particular for surgery, and greater for diverticulitis with abscesses, in particular with pelvic abscesses in inch 2 and distant abscesses. And this is just for surgery and also for relapses that are more frequent in patients with inch 2 than for inch 0 and inch 1. Considering that complications of diverticulitis can be managed non-operatively, the use of intestinal ultrasound and SEERS can be very useful to monitor the patient and their complications, even in the short term, and avoiding repeated computed tomography. In this patient, the SEERS was used to assess the outcome of an abscess, here very, very large, and then it was repeated after a few weeks, just showing the presence of partial or almost complete recovery of the abscess. Ultrasound is already currently used in our clinical practice to manage and to monitor conservatively acute diverticulitis. You can see here a patient with an acute diverticulitis, and with ultrasound we show weeks later, the disappearance of the diverticulitis. The use of ultrasound in assessment of and usefulness, its usefulness in assessing acute diverticulitis has been suggested years ago and proved to be effective. Although for patients with mild to moderate diverticulitis and dry colonic diverticulitis in this Japanese study. The last topic of my presentation is about symptomatic and complicated diverticular disease. Symptomatic and complicated diverticular disease of the colon, or SAD, is a clinical condition characterized by recurrent abdominal symptoms, mainly abdominal pain and bloating, quite similar to an IBS. But in this syndrome, all symptoms are attributed to the diverticula in the absence of any other macroscopically evident alteration. Despite its similarity with IBS, SAD have a more localized pain, usually present in left iliac fossa. There are other criteria or other features that can discriminate between symptomatic and complicated diverticular disease and IBS, not only the localization of the pain, but also the pain lasting for more than 24 hours, that is more frequent in the history of diverticular disease, and usually mild to moderate pain is most frequent in IBS and more severe in diverticular disease, and also the improvement after bowel movements is typical for IBS but not typical for diverticular disease, and also the mild inflammation revealed by the increase in fecal calprotectin is more common in diverticular disease instead of IBS. And ultrasound may be useful to detect diverticula in this patient. You can see here a diverticula with a shadowing, and also in this video it is clear the diverticula here with a shadowing effect of a coprolite inside of the diverticulum. And the accuracy of ultrasound in detecting diverticula has been published years ago, more than 20 years ago, in this study, showing that the sensitivity and specificity of ultrasound is above 80%, 85%. And more recent data by our group show that with new machine we can also assess the presence of the diverticula using colonoscopy as a reference standard with a sensitivity and a specificity above 95%. But probably ultrasound is able also to detect other features of symptomatic diverticular disease of the colon. And which are these criteria? We know that in SAD there is a mild inflammation that is increased in patients with symptomatic diverticular disease, and of course in patients with acute diverticulitis, compared to patients with asymptomatic diverticulosis. And we know that in diverticular disease there is an increase, of course, of visceral hypersensitivity. In fact, the pressure threshold to first reported pain is lower in patients with diverticular disease compared to the asymptomatic diverticulosis and healthy controls. And also we know that there are neuromuscular functional abnormalities in patients with SAD compared to patients with IBS. This has been already shown in another section of this meeting. However, so far, we do not have a specific diagnostic test for SAD, in particular one test that is able to assess all the above mentioned physiological changes. In fact, we know that colonoscopy and other invasive exams, such as CT colonoscopy, can detect diverticular, but the scientific society do not recommend this investigation for patients with suspected SAD, as well as for symptomatic patients who have been already investigated with colonoscopy and had a negative fecal occult blood test. And so, in SAD patients, intestinal ultrasound can detect the diverticula, can assess myelin inflammation, and also pushing with the probe just exactly in the correspondence of the diverticula and increasing the pressure with the probe above the colon, we can stimulate and just evoking the symptoms that usually are complained by the patients. And we use these features to assess specific features of patients with a symptomatic and complicated diverticular disease. In this preliminary study, we compared the thickening of the muscularis propria and just assess a differential score pain just above the pain, just above the sigmoid colon and far from the sigmoid colon. And we show that in patients with symptomatic and complicated diverticular disease, there is an increased thickness of the muscularis propria, but particularly a differential score pain compared to patients with IBS and non-IBS patients with symptoms and diverticulosis. And so, in summary, we can suggest that ultrasound and also CT scan are, of course, a useful tool to detect acute diverticulitis and possibly to be used in the sequential way. Ultrasound with intravenous contrast agents used can help in discriminating abscesses from phlegmons and properly assess the size of abscesses. And ultrasound can monitor acute diverticulitis, but is not proved its usefulness in predicting so far the long-term outcome. And probably in the future, ultrasound could help in measuring appropriately symptomatic and complicated diverticular disease. Thank you for your attention.
Many thanks, Giovanni, for the excellent lecture and the special findings. My name is Gerardo Nardone, and first of all, I would thank Antonio and Giovanni for the kind invitation to this excellent meeting. Now it is a privilege and honor to introduce the next speaker, Emmanuel Theodoropoulos. He will talk about the computed tomography and other radiological tools. Please, Emmanuel.
Thank you for the invitation to speak about the diverticular disease and the radiology tools we have. First of all, I would like to remind the definitions of the entities around diverticular disease. Diverticulum is a sac-like protrusion of the colonic wall that consists of mucosa, submucosa and serosa. Diverticulosis is the presence of diverticula, often an incidental finding. Diverticulitis is the inflammation resulting from a perforation of a diverticulum, and diverticular hemorrhage is diverticular bleeding, usually not associated with diverticulitis. I will not talk about anatomy, epidemiology, pathophysiology, clinical presentation or differential diagnosis. We already have seen them in previous presentations. I only want to remind that diverticulitis is the most common clinical complication of colonic diverticular disease, and diverticulitis results from obstruction at the neck of a diverticulum leading to localized inflammation. We have many radiologic tools for the diverticular disease, but only one can give us the information we need. The plain abdominal X-ray is useful to exclude significant abnormalities in intestinal passage and free intra-abdominal gas. It is not suitable for detecting diverticulitis. Sonography, we have already heard about the method. It is highly dependent on the ease of imaging and the experience of the practitioner. Barium enema, which is performed very rare today, is not sensitive for detecting peridiverticular inflammation, abscesses and fistulas. Computed tomography is the method of choice, also for recognition of the complicated disease. CT-guided drainage is possible when we have an abscess or a collection. MRI is used in trials and the routine use is still premature. Colonoscopy is mainly indicated for the reliable exclusion of tumors during periods free of inflammation. And angiography is used for lower GI bleeding and embolization. So computed tomography has become the gold standard. We give to the patient oral, rectal and intravenous contrast media, and the scan is performed in a portal vein phase. In modern multi-detector computed tomography, primary layer collimations of 0.6 to 1.5 millimeters are primarily selected. Multiplanar reformatting can be used to improve the presentation and documentation of the findings. The radiologic findings in diverticulitis are symmetrical thickening of the inflamed intestinal wall, normal thickness is about 3 to 5 millimeters, with segment size more than 10 centimeters, a sign with high sensitivity, diffuse edematous infiltration of the pericolic fat tissue, and this sign has also high sensitivity. We can also find fluid accumulation around the root of the mesentery. Abscess is defined as a fluid-containing mass with or without air and enhancing wall. 35% of the patient with diverticulitis have a small abscess. Colovesicular fistula or fistula between colon and uterus or urinary bladder can be indirectly inferred from the gas in the adjacent organ. And some rare complications are the hepatic abscess or the septic thrombosis of inferior mesenteric vein. Some images from CT scans, images of a patient with diverticulosis. We can see the thickened sigmoid wall and the diverticular outpouchings. There is absence of adjacent fat stranding, so there are no findings of inflammation outside of the colon. In this patient with diverticulitis, we can see the wall thickening, but also fat stranding, which means inflammation adjacent the colon. This patient had severe diverticulitis with perforation. We can see the sigmoid wall thickening, small amounts of free fluid, extraluminal air, and extravasated luminal contrast media. An abscess can be found up to 1/3 of the patients with diverticulitis, and many times we have to drain it under CT guidance. The modern angiographic machines are able to perform cone beam CT, a kind of computed tomography, and we can combine CT and fluoroscopic guidance for placing needles or catheters in difficult places. In deep pelvic abscesses, many times we have to put the drainage catheter transgluteally. If we put a catheter in a pelvic abscess, probably we have to keep it for a couple of weeks, and we have to flush it because the catheters can block. Colovesicular fistula is a rare finding secondary to diverticulitis. These images of a patient with diverticulitis show thickened and inflamed sigmoid colon and air in fistula tract extending to urinary bladder. And in the lower image, we can see air and contrast media within the urinary bladder. Hepatic abscess is also a rare finding secondary to diverticulitis. This 85-year-old man with diverticulitis and fever under long antibiotic therapy revealed a loculated fluid collection in the subdiaphragmatic area of the liver. In liver abscesses, we prefer to place a needle in the cavity under ultrasound guidance, and then we can switch to fluoroscopy guidance. With the Seldinger technique, we insert the guide wire into the cavity, and after dilatation of the tract, we place the pigtail catheter. After the drainage of the pus, we can inject contrast to opacify the cavity. There are several systems for staging of diverticulitis and many trials to correlate the different stages with radiologic findings. In this paper, the modified Hinchey classification was well correlated with CT findings like colonic wall thickening, pericolic fat changes, abscesses, or free gas. The purpose is to help the staging with radiologic imaging. For example, stages 3 and 4 require emergency operative treatment. In another study, the stages of Hansen and Stock classification were correlated with CT findings. The authors correlate the radiologic signs with the outcome of the patients, like the operative treatment or the recurrence. And in another paper, Ambrosetti suggested another classification based on CT findings with detailed radiologic signs. This classification is very precise about the registration of the findings. The last part of diverticulum disease, where radiologists have a very important role, is the lower gastrointestinal bleeding. In other words, bleeding from the distal ileus to anus. There are several causes for lower gastrointestinal bleeding, like neoplasms, angiodysplasia, hemorrhoids, ischemic colitis, etc. But diverticulosis is the first cause with a percentage of 17 to 40%. 80 to 85% of bleedings stop spontaneously with conservative treatment. The diagnostic and therapeutic strategy for a patient with lower gastrointestinal bleeding is first hemodynamic resuscitation, correction of anticoagulation, INR, platelets, etc., and colonoscopy after adequate colonic cleansing. If there is recurrent bleeding after colonoscopic treatment, or there is no time for colonic cleansing and colonoscopy, we have to think angiography and embolization of the bleeding site. If possible, we perform CT angiography before angiography, because we can localize the bleeding site and we can map the anatomy of the vessels. CT angiography has high sensitivity. The bleeding rate we want to see the extravasation of contrast media is very low, less than 0.3 to 0.5 ml per minute. If we have a negative CT angiography, then angiography is unlikely to reveal the bleeding site. Probably bleeding has stopped, and of course we have to beware for intermittent bleeding. And an example of an 85-year-old man with massive lower gastrointestinal bleeding. The patient underwent colonoscopy, which found a bleeding diverticulum. The endoscopist put a clip and stopped the bleeding. But few hours later, there was a new massive hemorrhage again. The patient transmitted to the angio suite for emergency angiography. The angiogram with the catheter in the inferior mesenteric artery opacified the diverticulum at the sigmoid colon. After superselective catheterization of distal inferior mesenteric branch, the diverticulum opacified again with extravasation of the contrast media in the lumen of the colon. We placed superselectively 2 microcoils in the arteries which supplied the diverticulum. Microcoils are tiny wires which, when deployed, become spiral in shape and block the vessel. In the final angiogram, there is no opacification of the diverticulum, there is no extravasation anymore, while all the other branches of inferior mesenteric artery are patent. Embolization success rates for primary hemostasis vary between 83 to 94%. 27 to 34% of patients suffer of renewed bleeding despite successful primary embolization. It should always be in mind that intestinal wall ischemia is a possible complication. In summary, CT is a highly specific and sensitive imaging method in the evaluation of acute diverticulitis. It is the most accurate imaging technique available for the assessment of the inflammatory process, and CT-guided percutaneous drainage of diverticular abscesses plays a crucial role in improving patient outcome. Thank you.
Compliments for the excellent talk. Now the next speaker is Amin Ayal, and he will talk about the role of endoscopy in the diagnosis of diverticular disease.
Thank you very much for the invitation. My name's Amin Haji. I am a colorectal surgeon and interventional endoscopist at King's College Hospital in London. And it's a great honor for me today to speak to you about diverticular disease, and in particular how we use endoscopy in its management and intervention. Endoscopy for diverticular disease has primarily been used in the past for lower GI bleeding. And in fact, diverticular disease accounts for up to 40% of patients that are admitted for lower GI bleeding. And it's often related to the rupture of the vasa recta at the dome of the diverticulum, because these are false diverticular, where there is devoid muscular wall in the diverticular pouch. The diagnostic yield of colonoscopy is high, and up to 90%. It is important and imperative that patients have bowel preparation so that adequate views are seen during the index colonoscopy. There are many people that have tried to actually score the different areas for lower GI bleeding, and this is one particular score that has been used in the literature, which is the Oakland score, and a score which is less than 8. Often these can be treated as an outpatient, and those that score high, more than 8, need admission for therapy as an inpatient. And the score is calculated with different variables that relate to age and sex and previous hospital admissions or hospital history of lower GI bleeding, and if there is in particular blood present on rectal examination, whether patients have had any hemodynamic compromise in terms of tachycardia or hypotension, and also their hemoglobin levels at admission itself. So we tend to sort of use this really primarily as a research tool, but however, it's very useful for junior doctors to have this in mind when they're thinking about admission. So who would we actually scope in this particular scenario? Well, this is one particular diagram that will help in that. And once again, once you have assessment of the patient who is admitted with lower GI bleeding in terms of the Oakland score, and you calculate their actual shock index, and if they are stable, then patients will actually, if they are go on to either having admission and treatment, if this is a major intervention, and if it's a minor bleed and they're stable, they can be discharged and treated as an outpatient. Of course, if patients are unstable, I think it's important to undergo an interventional angiogram in order to identify where the bleeding point is. And often this can be treated with interventional radiology, or this can be focused with endoscopic treatment. Well, what sort of endoscopic considerations would we take into account? Now, we've talked about who we might scope in this scenario. One thing to consider really is that the risk of perforation during diverticular disease is much higher than those patients that are not diverticular. But this is particularly so in the emergency situation, because often bowel preparation is not as clear. And this is really related to the increased number of false diverticular, and there's a distortion in the anatomy and a much thinner muscular layer. And the bowel preparation itself, will give you a lower risk of perforation, and it does improve the diagnostic yield, so it would encourage you to do that, particularly in patients that are stable. It also enables us to identify the stigmata of recent hemorrhage, which is very important. I think techniques that we would use a cap, which is a straight cap, a transparent hood at the end of the endoscope. And what this allows you to do is allows you to retract and identify the openings of the diverticula carefully. And then we can also use a water jet, which is through the scope, that can irrigate the area and identify areas of bleeding, and also remove debris and fecal debris from within the diverticula. There are many endoscopic methods that might be used for treatment in such a situation. We can either use injection or thermal treatment, clipping, which I'm going to talk about in much more detail, band ligation, hemostatic powders or other powders that might be, and solutions that might be beneficial in major hemorrhage, and also over-the-scope clips. Let's take each of these in turn and look at their data. In terms of injection and thermal therapy, I must say in my practice, I don't tend to use this very much because often there's a risk of perforation with heatoprobe and bipolar diathermy. It might be used if certainly clipping or banding is technically extremely difficult and we have no choice in that situation, and you see an area of hemorrhage. I don't tend to use adrenal injection in the colon because it does tend to have a very temporary effect, not as much of a mechanical effect like it does in the duodenum. So that's just really gone out of fashion. I think the mainstay of treatment really is related to endoscopic clipping. What we would do in this situation is you have a transparent hood. This is then used to identify the aperture of the diverticula. Suction is applied, and then the clips are applied across the muscular layer on alternative air on the opposite sides in order to oppose the diverticula and close the aperture. This tends to cause minimum tissue damage, and also there's no need to withdraw the scope and use any other adjuncts because it can be done as through the scope clips. It also offers direct placement, particularly it's optimal for hemostasis. And if you're not able to identify the exact area and close the exact area using clips, you can use a zipper technique where you would actually compress either side of the bleeding point with 3 or 4 clips, as is seen in the lower photograph. What about band ligation? This once again requires sort of loading of the device externally, so withdrawal of the scope, loading the band ligators, and then reinserting it. But the technique is very similar to that used in upper GI, and is a secure method of tight closure of the muscularis propria. It requires us to actually potentially remove the scope and then put the device on, and then you suction into the ligator cap, and then release the O-ring and the band to completely close the muscularis propria. Delayed perforation is possible with this technique, but although it's rare, so something to watch out for, and it does tend to reduce the risk of rebleeding as it does with clipping. In terms of hemostatic powders, I think this is not really licensed for lower GI bleeding, but often we do use it in major hemorrhage, particularly if we cannot identify a bleeding point in an area, and you'd use a hemostatic powder to then reevaluate at a later date. All this can be used in conjunction with interventional radiology. In terms of over-the-scope clips for bleeding, I think this is actually very, very difficult and rarely used in diverticular disease. It's more used really in post-op leaks or GI perforation, but once again, it requires a withdrawal of the scope and then reinserting the device as an over-the-scope device. So it's not really used in the acute stage of diverticular disease. So in terms of endoscopic methods that we would use for treatment of diverticular bleeding, I mean, the issues really are that you can get rebleeding either early or late, and it usually only addresses if you can identify the exact spot where the bleeding is coming from the diverticula, and doesn't tend to act as a preventative measure, because obviously in our current practice, we wouldn't usually clip every diverticula that is seen. Now, what about elective endoscopic clipping? Is this a potential for cure? And this is something that we published in Gut several years ago. And this was an initial pilot study where there was a prospective single-center study at King's College Hospital, where we had 9 patients that were previously admitted with lower GI hemorrhage. And what we did is that we identified these patients and we clipped every single diverticular endoscopically using a cap and irrigation in the methods that I've described in the previous 5 minutes. And what we did really is once we placed these clips, we would follow up these patients at 3 months with another routine colonoscopy. The procedure length on average was 35 minutes, so much longer than a routine colonoscopy. And we placed a median of 17.5 clips and up to 29 clips in these patients. So what about the results from the clipping study? What we found is 129 out of the 148 diverticular were completely closed. That's 87.5%. But you can see here really from the images in the slide, you can see on the top diagrams, you have the diverticular present and the clips that are applied. And the bottom diagrams are the white light and spectral imaging of the scar that you can see post-diverticular closure at 3 months. There were no post-procedural complications, and therefore we deemed this to be a feasible and safe procedure. And of course, this needs further larger randomized studies that need to be undertaken to see whether this is actually useful. So where do we go next from our initial pilot study? And what we've actually then gone on to do is a prospective randomized placebo trial where the patients are actually blinded of prophylactic endoscopic clipping of colonic diverticular. And we've named this a PECOT study. The aims and objectives of the study is really to look at the rate of diverticular closure, to really evaluate whether elective endoscopic clipping of diverticular leads to a permanent closure of diverticular defects. We also need to establish the clinical effectiveness and whether actually symptoms associated with diverticular disease will improve as a result of clipping. And the main objective, really, we would say this is an effective study if we were to see a 25% reduction in the pain parameter score assessed by the irritable bowel syndrome symptom severity score. So this is a very interesting study which we started about 18 months ago. Patients were actually identified from our diverticular disease clinic, and we have a diverticular clinic that we run on a weekly basis. And all patients with diverticular disease, both complicated and uncomplicated, are evaluated and followed up routinely in this research clinic. We randomize patients using computer-generated block randomization and randomize them either to a placebo arm or an interventional arm. In the placebo group, we would map the colonoscopy with looking at the colonic diverticular in terms of the location and the number of diverticular. What we would also do is we would mimic the clipping procedure. So patients are blindfolded, they are sedated, and we would say that we would fire clips, but not actually doing so. And we simulated this instruction to the nursing staff, but no clips were actually placed within the bowel. And the interventional group, we did the same, but in this group, on withdrawal, we would clean all the diverticular with a flushing pump, and then all visible diverticular were counted and recorded and closed with endoscopic clips. And complete closure was really defined as complete approximation of the edges of the diverticular pouch without any visible defect on the mucosa. Any failure was recorded, and we'd also take biopsies from the colon, and these biopsies are taken from the right colon and from the left colon, both from peridiverticular areas and diverticular areas. Patients all receive a telephone consultation the next day, in addition to our routine follow-up. In terms of follow-up, what we would find is, we would do follow-up at day 7 and day 28 and 90 in the initial 3 months. Post-index procedure, they would have a clinician consultation, plus we'd had repeat bloods and looking at their stool samples and urine and saliva samples. We've also done the similar at 28 days, and are similar at 90 days as well when we do our follow-up at 3 months. When there's a follow-up at 3 months, this is a follow-up colonoscopy, in addition to patients having bloods and stool tests and urine and saliva, and the biopsies were taken as well if needed. The recordings are also evaluated at this stage in terms of video recordings, as with the index procedure, and we would identify whether there are any visible scars or whether there's any evidence of recurrence. We would also identify whether new diverticula are present, and these would be recorded. Patients are then also having a clinical review at 6 months, and the IBS questionnaire is also to be repeated. And then finally, at the end of trial at 12 months, these patients will all have their routine bloods and stool tests and questionnaires, and a final colonoscopy to be repeated to assess for recurrence and restaging of their diverticular disease. And each endoscopic procedure in the whole program was recorded by video. And this is what we can see in the PCOD trial at 3 months. You can see that this is evidence of different scarring, some granulation tissue, and some areas where you've seen complete scarring and closure of the diverticula. I just want to finish really on showing you a video of how the diverticular clipping is taking place in the trial. Here you can see the different types of how the diverticular might present. This is a soft diverticular, as I term it. You've got a cap at the end of the endoscope. You're irrigating using water irrigation. And what we're doing is gently sucking the diverticula, and you can see that the diverticula here is completely inverted. And at this stage, it's fairly easy to clip the diverticula because the inverted portion of the diverticula can be easily clipped and applied and therefore closed completely. This is another example of the diverticula where you've actually got the area that you cannot invert. And you can see here that it's actually unable to invert it, so we're irrigating. And once we've irrigated it, what we would do in this situation is just apply the clip on either side of the mucosal aperture and then close. And that's another example of how we would close a diverticula. And all diverticula that are visible are closed in this manner. Even larger diverticula like this one, if you apply sufficient pressure and then suction, we can then close a diverticula completely just using one clip. So in summary, ladies and gentlemen, there are many endoscopic treatment options, particularly for diverticular bleeding that are established. And I think there is ongoing research that's needed in order to identify whether endoscopic intervention is actually beneficial to patients with symptomatic diverticular disease. And the results of the PCOD trial, which hopefully we will publish next year, should be very interesting to see if this produces symptoms in patients with diverticular disease. These are my references, and I thank you very much for your time. Many of you will join us in our live interventional endoscopy conference this November, which is King's Live on the 3rd to the 5th of November. Thank you very much for your time.
Thank you, Amin. Thank you, Amin, for an excellent presentation. It's very good, interesting. Antonio Turzi, I give the floor to Antonio Turzi for DICA.
Okay, thank you. And this presentation will show you how the DICA classification have been developed and validated, and the results of the prospective study, which will be published in the next weeks in GAT. Please. Good morning, ladies and gentlemen, dear colleagues. Once again, thank you for attending to this interesting meeting. In this presentation, I will show you the role of the DICA endoscopic classification in scoring the endoscopic finding of the colon having diverticulosis and diverticular disease, and in predicting the outcome of the disease according to its items. We have several scores for different diseases of the gastrointestinal tract. We have endoscopic score for bleeding ulcer, for inflammatory bowel disease, for esophagitis, and each of them is important not only in order to describe in an objective way the endoscopic damage, but also to predict the outcome of the disease. And what about diverticular disease? And in particular, why to develop an endoscopic classification for diverticulosis and diverticular disease? First of all, because diverticulosis is the most frequent finding of the colon during a standard colonoscopy. Another important point to consider is that it's quite easy to recognize endoscopic finding of diverticular inflammation during standard colonoscopy. In this study published about 20 years ago, authors found that about 1% of people with diverticulosis may had signs of diverticular inflammation. And this finding was confirmed also by our group 10 years later. And in fact, we found that signs of diverticular inflammation may be found in about 2% of people having diverticulosis during a colonoscopy. Moreover, we found that the number of diverticular and the extension of diverticulosis may be a risk factor not only for the recurrence of symptomatic and complicated diverticular disease, but also for the occurrence of acute diverticulitis. And finally, we found that the persistence of endoscopic inflammation after an episode of acute diverticulitis may be a risk factor for the recurrence of the acute diverticulitis. Considering all of these findings, in 2012, we developed and validated, together with 32 Italian endoscopists, the first endoscopic classification of diverticulosis and diverticular disease, which was called DICA, which is the acronyms of Diverticular Inflammation and Complication Assessment. This classification was developed according to 3 different steps. The first was the identification of endoscopic findings, and we scored them. The second was the assessment of the reproducibility, and finally, the last step was the assessment of the agreement about the main items and the sub-items. This classification takes into account 4 different and 4 main items: the extension of diverticulosis, the number of diverticula per colonic district, the presence and type of logistic finding, and finally, the presence of endoscopic classification. Each main items show also several sub-items, and each of them was scored. The sum of the score leads to 3 different steps of DICA. DICA 1 up to 3 points, DICA 2 from 4 to 7 points, and finally DICA 3 over 7 points. According to this classification, the main and the sub-items of the classification, what was the feature that are very important to consider to have a good classification? So, namely, why we can develop an endoscopic classification and how this classification should be assessed in order to be considered very useful in clinical practice. Generally, we have 2 points to assess. The first was that the classification must be easy to use with a high level of reproducibility according to the agreement about each specific item assessed. And the second point was that this classification, any new classification, must have a predictive value in order to assess its impact on the outcome of the disease. Starting from the first point, namely the assessment of the use, if this classification was easy or not to use. In the first study, namely when the classification was developed and validated, we found that we had a significantly high score, agreement among the endoscopists, not only about each specific score of the Dickler classification. On the left, we can see that the flex kappa was very high for each score, namely for each one, DICA 1, DICA 2, and DICA 3, but also the intracerebral agreement kappa was very, very high because it was higher than 0.9. And on the right, looking at each of the different items of the classification, we can see that the concordance was very, very high, and in particular for stenosis and bleeding, it was also almost complete because it was 1. Of course, we have also a significant relationship between the severity of DICA score and some specific clinical characteristic, for example, the severity of the abdominal pain or the levels of CRP and ESR. The further step was to validate this classification and to assess the reproducibility in a clinical setting. This is the first study which was conducted enrolling and involving 66 Italian endoscopists. We split the colleague as expert, namely colleague who was expert in using the Dickler classification, and not expert, namely colleague who did not use or did not know the Dickler classification. And the overall agreement was at least good, not only in expert but also in non-expert, and this was very high in each score of Dickler classification, in DICA 1, DICA 2, and DICA 3. And looking at the different items of the classification, the overall agreement was very interesting because it was very high, as expected, in the expert group, but also good in non-expert group of endoscopists. This shows clearly that, at least in the Italian endoscopist community setting, the classification was easy to. The following step was to assess the reproducibility in an international setting. This is a study conducted during the 3rd international meeting on diverticular disease and involving 96 physicians coming from Europe, Africa, America, and Australia. And about 80% of these physicians were endoscopic. Again, the overall agreement was very high because it was higher than 90%. We subdivided the colleagues as, again, users of Dickler classification and not users of Dickler classification. Overall, the agreement was very high, both for users and not users. And again, looking at the specific items of the classification, we found that, again, the overall agreement was significantly high, not only for expert, but also for non-expert. Again, also this study conducted in an international setting, we found that the Dickler classification show a significant agreement between endoscopies. So this means that this classification seems to be really easy to use in clinical practice. Moving on, the second important point in order to assess a classification, namely assess the predictive value. As expected, the first study assessing the predictive value of this classification was a retrospective study, which was conducted in Italy and in Europe. This study was published in 2015 and found clearly that the risk of occurrence and recurrence of acute diverticulitis and the risk of surgery occurrence was strictly linked to the severity of Dickler classification. Namely, patients on DICA 3 were at higher risk to have the occurrence of acute diverticulitis or to have a risk of surgery than in patients having DICA 2 or DICA 1. And looking at the right of this slide, we can see clearly that at the multivariate analysis, only the DICA score was the predictive value of the occurrence of this complication. These results were confirmed by another Italian study published by our group, a mixed study, retrospective, prospective, published by our group. The last year, we found clearly that the patient on DECA-3 were at higher risk to have occurrence of diverticulitis, to have occurrence of complicated diverticulitis, to have hospital admission, to have more length hospital stay, and as expected, more expensive hospital stay than people scored as DICA2 or scored as DICA1. In this study, we enrolled 2,215 patients at the first diagnosis of diverticular disease. All patients were scored according to DICA classification, and we assessed in those people symptoms and also some specific clinical characteristics. If we look at the baseline demographic and clinical characteristics in those people, we can see clearly that some specific demographic and specific clinical symptoms are strictly linked to the severity of the DICA score. For example, patients on DICA3 were more frequently older people, were female, were smokers, showed appendectomy and presence of comorbidity. And as expected, according to retrospective study, in patients with DICA3, we have more frequently more severe symptoms, ranging from abdominal pain to changes in bowel habits, than people on DICA2 and DICA1. And these are the primary endpoints of the study. As expected, again, people on DICA3 were at a higher risk to have acute diverticulitis occurrence recurrence and a higher risk to have surgery than people on DICA2 and DICA1. The risk was significantly different, as we can see in at the bottom of this slide. And we can see clearly that, again, the severity of DICA score is strictly linked to the more severe outcome of the disease during a 3-year follow-up. The further step was to try to combine the endoscopic characteristic of this classification with some specific clinical characteristic, leading to a new score, which was called CODA. CODA is again an Italian acronym, which is the acronym of Combined Overview of Diverticular Assessment. And this score is very important. Why this score is very important? This score is important because it combines the DICA classification and the severity of abdominal pain and the age of this patient, because from the multivariate analysis of the DICA study, we found that the severity of abdominal pain and the older age were the stronger factor about the risk of diverticulitis and surgery. And this score, applied to a 3-year follow-up, was very important in order to construct the prediction of the outcome of the disease. This is on the left how the scoring system was developed about the scoring of each parameter assessed. It leads to 3 different CODA score: A from 3 to 9, B from 10 to 6, and C over 16. And on the right corner on the bottom, we can see clearly that according to the number, the scoring, the sum of the score, we can significant and rapid increase of the risk of diverticulitis and surgery in those people. And these slides show clearly the predicted value of the CODA score. Again, we can see clearly that the 3-year cumulative probability of the diverticulitis was significantly higher in CODA C than in CODA B and in CODA A. And again, it was confirmed also by surgery. Namely, in other words, if we combine the endoscopic classification and the endoscopic score together with a clinical characteristic constructing the CODA score, we have a significant discriminant capability to predict the risk of some specific point. We are able to predict the evolution of the disease during a 3-year. So coming back to the question at the beginning of this presentation, namely if this classification may be really easy to use, and if it has a predictive value, I showed you, clearly that this classification is really easy to use with high level of concordance among endoscopists, and this classification has shown also a very important role in predicting the evolution of the disease in terms of risk of complication. And in fact, the statement from the Third International Symposium on Diverticular Disease described clearly that DICA classification has a significant predictive value on the outcome of the disease. So in conclusions, ladies and gentlemen, the declassification is simple and easy to use and show also a high reproducibility rate. Not only, but this classification show also a very important role in predicting the outcome of the disease in terms of risk of acute diverticulitis and surgery. And this role is significantly enhanced when we construct the CODA score, which combines the DICA score and the 2 clinical parameters, namely the age of the patient and the severity of the abdominal pain. And so probably the DICA classification, and in particular its evolution, the CODA score, that should be considered the new tool in order to stratify better patient having diverticulosis and diverticular disease detected during colonoscopy, also to design new trial in order to identify which patient need a treatment and which patient should be only clinically observed during the follow-up. Thank you very much for your attention.
Thank you, Antonio. Excellent presentation. Now we can start with the discussion. Do you have some questions? I can start. Walter, can you go to the podium? I want to ask you if you use the fecal calprotectin in your clinical practice, and if yes, when?
When? I use fecal calprotectin when I want to make a diagnosis of diverticular disease, and when I want to assess the response to therapy during the follow-up of these patients.
Okay, thank you very much. You have?
I can, Giovanni?
One question.
Yeah.
One question for Amin. Amin, ci sei? Sì?
Yes, yes.
Amin. Yes. Which is the timing endoscopy in diverticular disease?
So I think, for patients that present acutely, then we would try and do their colonoscopy within 48 hours of admission for lower GI bleeding. For patients that have had previous diverticulitis and are symptomatic diverticular disease, we would wait for 6 weeks for elective endoscopic clipping rather than go in acutely to do the clipping. So it really depends on what we're trying to achieve, whether it's for bleeding or whether it's on the symptomatic path to treat the diverticular electively.
Okay, thank you. One moment.
Giovanni?
Just a question. But in which patient do you perform the clipping of diverticular? In all patients or only in a symptomatic patient?
So currently this is the context of a randomized trial that's blind at the moment. So these are patients that have symptomatic diverticular disease across the spectrum, and then they are randomized to clipping or placebo, and the patients are blinded to the clipping, and then we now have introduced a crossover at 12 months. So currently the clipping for symptomatic patients is purely in the context of the randomized trial. For lower GI bleeding, we are offering clipping only if we can identify the area of the actual GI bleeding, and often this is done in combination with identifying either on interventional radiology, an endoscopic assessment to see if you've got recent stigmata of hemorrhage, and then we would do the clipping of the individual diverticular at that stage. So it's a little bit more challenging in the bleeding patient because you don't always identify exactly where the bleeding is coming from.
So another question to Agi. But do you perform this clipping to prevent diverticulitis? But is cost effective?
So I think these are very good questions, and I think we need to wait for the results of the randomized trial to see if there are a subset of patients that would benefit from clipping and improving symptoms. Whether we are preventing diverticulitis, it requires a much longer study with longer follow-up. And our plan is to continue follow-up for these patients over the next decade post-clipping with regular questionnaires so that we can identify whether there's a reduction in patients that are admitted for diverticulitis. But I think that sort of question is going to be very difficult to answer in the short term. Certainly what we have found, and what's very interesting, is patients who are symptomatic with abdominal pain and bloating, and particularly with isolated sigmoid diverticular, when we do clip their diverticular disease, and we may have to put 20 or 30 clips in their left colon, we do find that a percentage of these patients are free of abdominal pain at their follow-up at 1 year. And that's very interesting, and I think we need to evaluate that further. So I think hopefully we'll have some more answers next year when we publish our first randomized trial.
Okay, thank you. There are questions? Gerardo, do you?
Yes, okay. I have a question for both, for Emanuele Theodoropoulos and Giovanni Maconi. What do you think about to perform ultrasound in emergency room as the first step? Then we can classify correctly diverticulitis by tomography, but then we can follow the patients only with the ultrasound.
Okay.
In my experience, CT scan is the best and the gold standard. We can see everything. We can see complications. We can see an abscess. After this, we can follow up the patient with ultrasound and find specifically signs and follow the special finds, the fluids to see if they are grow or they are less. So I think the first choice is CT scan, and then we can follow up the patient with ultrasound.
Okay. I believe that since most of our patients are patients with a very mild diverticulitis, because also in the emergency room, more than 50 or up to 80% of patients have a very mild diverticulitis. I feel that we can start, if you have a good sonographer, with ultrasound. it is very important to have simultaneous examination, because you can follow the patient with ultrasound, but you have to know if it is possible to see with ultrasound the lesion. So anyway, if you have a CT scan, that is of course the gold standard also in my opinion, because a more panoramic view, it can use contrast to see better the collection. You have to know if you are able to see with ultrasound the same lesion you can see with the CT scan. In this way, you can correctly monitor your lesion. Otherwise, you don't know if it is possible to have the evaluation in the follow-up. This is the main problem in my opinion. So anyway, if you perform ultrasound, the CT scan, you decide to follow the patient with CT scan, you have to know if it is possible to see the same lesion you can have seen with a CT scan.
Okay, thank you.
Many thanks, many thanks.
Emmanuel. So a question for Antonio. So a question for Antonio. Do you know that not all the endoscopies classify with the DIGA classification the endoscopy? Do you think that it's possible to classify, to use the classification retrospectively? So if I have a colonoscopy with a diverticular disease and the endoscopist didn't use the DIGA score, it's possible to use this DIGA score?
Good question, Giovanni. It depends about which is reported in the description of in the old description of the colon. If we have all parameters reported, the number of diverticular, or at least if we have a scattered or extensive diverticulosis, and if further describe the characteristic of the diverticular with or without inflammation, and possibly also which type of inflammation, absolutely, yes, we can try to classify retrospectively those patients, in particular patients that undergo colonoscopy every 5-10 years according to the colorectal cancer screening, or also in patients with recurrent abdominal pain. All depends on the description of the colon. And if we have a good description, we can try also to apply the classification also in retrospective fashion.
Okay, thank you. I think that we are in time, that we can close this session and we can start with the next session. And Savas, I give you the floor.
Thank you very much. Very happy to be in this great meeting. And I already have a long list of questions, so I won't have time to ask myself. We're passing now to surgical topics. And the first speaker is Dr. Ricardo Escalante, and we're going to hear about urgent surgery in diverticulitis.
Cari colleghi, cari amici, voglio ringraziare il comitato organizzatore per l'invito a partecipare a questo simposio internazionale. Grazie molte. This is the real situation about diverticulosis around the world. Then our interest in diverticular disease, and of course, the interest of surgeons about its complication. When we search about complication for diverticulitis, we can find too much information on the web. For example, this is the web page of the American Society of Colon and Rectal Surgeons, where people could easily obtain this kind of information. During my presentation, I'm going to talk mainly about peritonitis. Other invited speakers will talk about abscess, obstruction, and fistula. As you know, urgent surgery for diverticularis are very common in population over 60 years old. The difference about gender is different depending on the paper. The main indication for emergency surgery is the same. In all the papers and books that you try, diverticulitis is the first indication, followed by rectal bleeding and fistula. When we review indication for emergency surgeries and collect different statistics, then phlegmon, abscess, and perforation add 71%. This graphic is very clear. Just few words about history. The first case of the literature was reported by Rolleston more than 1 century ago. In that opportunity, he washed the cavity and drained it. Look, no resection, no anastomosis, and no stoma. Please remember this slide during my talk. And look, the term diverticulitis was not used in that opportunity. He mentioned the disease as hypereosinoitis. Nowadays, the surgeons don't use this concept or term as surgical finding. For many years, we have used the Hinchey classification. This classification is very easy and has a good relationship between clinic, radiology, and surgical finding. Hinchey 1 and Hinchey 2 are for medical and radiological management. Different is the situation for Hinchey 3 and Hinchey 4. Surgical options for Hinchey 3 are controversial, and surgeries for Hinchey 4 are well established. During last years, many classifications has been reported, but Hinchey with modification remain as the more common. Here, you can look the last one. The last one was done by the World Society of Emergency Surgery. Okay, now let's go into talk about urgent surgeries. Mainly, there are two options, open and laparoscopic surgery. In open surgery, it is necessary to mention the Hartmann procedure. For many years, Hartmann procedure was considered the surgical gold standard for complicated diverticulitis. After 1960, began the controversy about anastomosis or not, with or without ostomy. Finally, anastomosis was accepted as a right option. With the arrival of laparoscopic technique at 19th, we began to use the same surgical option that we use in open surgeries, the Hartmann procedure and the primary resection with or without anastomosis and with or without protective stoma. By other hand, laparoscopic peritoneal lavage and robotic surgeries are another alternatives which bring controversies for surgical management of complicated diverticulitis. Then, which is the best surgery? The answer is very simple. Surgery alternatives are no cooking recipes for urgent surgery. We have to consider one surgery as one tailored suite. We have to be clear. If you are in a small hospital with basic resources, without laparoscopy, without intensive care, and without a surgical team, without training in laparoscopy, don't be creative. You have to solve the emergency. Then, open surgery is the best choice. for your safety and the patient also. Different situation if you are in a modern hospital in Italy, Malta, or Greece, with all the technology that you need and well-trained surgical group. You could do everything that you wish, even robotic surgery. The purpose of my presentation is not to talk about which surgery is better for urgent surgery. Everybody knows the different choice that we have and its advantage and disadvantage. I prefer to mention to you some news, tips, and tricks for complicated diverticulitis based on recent paper from 2018. 25 years ago, it was proposed a laparoscopic peritoneal lavage with drainage, without stoma and anastomosis. Do you remember the Rolling Stone slide? Now we are doing the same that he did more than 100 years ago. No resection, no anastomosis, and no stoma. Laparoscopic lavage is useful for Hinchey 3 and could be considered as a bridge for elective surgery at the future. This technique is controversial. Some international multi-center trials have done. Some of them are agree with the technique, but others are against. My personal experience with peritoneal lavage, I had a good results. In that small series, we didn't have mortality or major complication. Probably we were very strict to select patients. In that study, we conclude that it's a good alternative to be considered for a patient without comorbidities, and it's preferred to do it in centers with experience in laparoscopic surgery. Now, look this controversial alternative. 4 years ago, Dr. Keiji Koda from Chiba, Japan, proposed to drain diverticular abscess by endoscopy. In London, he presented a successful result in 9 patients. He proposed this technique for patients under the category of Hinchey 2. Look at the left side. This is a patient with a right side diverticulitis, very common in Asia. At the center, they drain the abscess by endoscopy with good results. At the right side, you can see the CT scan 1 month later, where the clinical situation was solved. Certainly, this approach is very interesting to discuss. One more controversy. Is it necessary to do an elective surgery after diverticulitis? How and when? It depends of every case. It's very important to have a support of this approach. Second, we need to identify the risk factor for elective surgery. And we have to be clear that in this case, the risk for construction of proximal ileostomy is high. Even synchronous resection, longer operative time, and length of hospital stay. In our meeting and Congress 5 years ago, robotic surgery was not considered as an alternative to solve peritonitis for diverticular disease. It was expensive, difficult to do it, and there were few teams with good training in this area. Now, the situation is different. Recent paper consider robotic surgery as a possible option for complicated diverticulitis. Another tip, leakage colorectal anastomosis represent an important rate of morbidity and mortality after any colorectal surgery. Really, it is a real worry for surgeons. It is necessary to use all the alternatives to prevent this complication. Now, in some centers, we have an indocyanine green. All the papers support that indocyanine is very useful. It's a good alternative to check vascularization of colorectal anastomosis. The indocyanine is very useful for open or closed surgeries. Ladies and gentlemen, during my talk, I have put on the table some questions. In medicine, we know very well that the best way to find answers is through international and multi-center trials. This is the Damascus study, which is collecting surgical and clinical information around the world. They are working in some centers in England, Australia, Ireland, United States, and Brazil, and have an academic support of important scientific associations. The Damascus study began at the beginning of last year, and it was supposed to finish on last December. But the pandemic situation changed everything. This international trial is collecting data about many aspects, diverticular disease, complicated or not, which include surgical and clinical outcomes, complications, mortality, cost, and much more. Also, Damascus is going to do a bank of information for future prospective studies. Don't forget this trial. Surely, in a short time, we are going to have more information about this exciting topic, diverticular disease. Once again, thank you very much for giving me the opportunity and privilege to share your time. Ci vediamo al prossimo simposio. Tante grazie.
So we go further. We spoke about the emergent surgery. I think that this is quite clear that inch 4 step, inch 4 classification is a clear indication for surgery. The problem is more questionable for elective surgery. And so we start with Roberto Persiani to see if he can give us some tips, new tips, information about this difficult subject.
Thank you very much. Open? Okay, thank you very much, Sirs. It's a great pleasure to be here for the 4th time. So I want to really thank Giovanni and Antonello for inviting me again. My task is to talk about the elective surgery in the treatment of a diverticular disease. And this topic is a topic on which there have been several changes in the past few years, because as I'm going to show you now, the indications are limited and we have to select patients not on the basis of the episodes, on the episode of acute diverticulitis, but on the basis of the patient quality of life. So, 2 main questions. The first one for our surgeon is when to cut the colon out, and the second one is how to cut the colon out. We are not in the setting of emergent surgery, we are in the setting of elective surgeons, and Riccardo Escalante has just said that there is some risk in the elective setting. Sometimes we perform more protective ileostomy than in an emergent surgery. So it's a topic very, very important to clear. So when I say when to cut it out, it means is still the number of acute episodes a parameter for offering surgery to our patients? Is there still any rule for early surgery in the prevention of the recurrence or in the prevention of perforation? And it's still valid the indications to treat patients by elective surgery only because they are young or only because they are an immunocompromised patient? So this is where we were until 2014, and these were the guidelines published by the American Society of Colorectal Surgeons and by the European Associations for Endoscopic Surgery. So two main goals for surgery. The first one was obviously treatments of chronic symptoms or complications related to diverticular disease, but most of indications was related to the preventions of recurrence, to the prophylaxis of recurrence. And so the indications were 2 episodes of uncomplicated diverticulitis, 1 episode of complicated diverticulitis, and 1 episode of uncomplicated diverticulitis in young patients, in immunosuppressed patients. This is where we are now. The indications for treatment of chronic symptoms or for patients with complications related to the diverticular disease is still confirmed, but the prophylaxis of recurrences disappeared. So now the main goal for elective surgery is to improve patients' quality of life. So we moved away from the dogmatic indications, and now the decision-making process has to be shared with the patients, balancing the severity of their disease, taking into account their age and the morbidity, and even considering the risk related to the surgical procedures itself. So regarding the uncomplicated diverticulitis today, the decision should be individualized. What we did in the past, and sometimes it currently happens, that if we want to persuade our patients to undergo surgery, we tell them that after each episode, they increase their risk to have colonic perforations or to have acute and more serious episodes. But now we know that the emergent surgery occurs in no more than 5% of patients. We know that colonic perforation usually occurs during the first episodes and is very, very rarely afterwards. And what we know is that recurrent diverticulitis do not increase the risk of perforations, but maybe reduce this risk just because it's due to the adhesions related to the inflammation. That's why now we have to individualize our decisions. But at the same time, now we know more clearly the risk of recurrence after each episode. So we know that this risk is roughly 90% after 1 episode, 25% after 2 episodes, and more than 35% after 3 episodes. And this is the way to go. We have to share this information with our patient, and this is the way to take the right decisions for the right patients in the right conditions. But what we are offering is something really effective. Is surgery good options for patients outside an emergent setting? Maybe yes. This randomized control trial is plenty of bias, but I think this is a stone. So we know that patients, if we selected patients very, very well, we can give them the chance to overcome the bad quality of life conditions. And this study compared patients with recurrent or ongoing left side diverticulitis with patients treated non-operatively. And the results was that at 6 months, and now we have an update after 5 years, patients who received surgery had good results, better results as patients not treated non-operatively. This is my short experience from the last 5 years. As you can see, we operated approximately 50% of patients for uncomplicated diverticulitis after recurrent episode of diverticulitis. Complicated diverticulitis is only 25% of these patients. Fistula is very, very rare, and stenosis is again 25% of these patients. More than 95% of these patients underwent the laparoscopic approach. The conversion rate was very, very low, and you can see 4 patients received a protective ileostomy. But the good news is that all of these patients received an ileostomy reversal after a few months. Yes, the anastomotic leak is a high risk, and so we have to balance our decisions with the risk that are related to our surgery. But as you can see here, if patients are good, well selected, the anastomotic leak rate, the overall complication rate, the reintervention is very, very low. And today, along with innovations in terms of surgical technique, we have also innovations in terms of clinical pathway, because we can offer to our patients, for example, the enhanced recovery after surgery protocols and these combinations, minimally invasive surgery and an ERAS approach, maybe can give us the optimum in terms of the good outcomes, good postoperative outcomes. So we say that now the indications depends on the patient quality of life, and we know that elective resections based on young age is not recommended. And again, immunosuppressed patients should receive surgery after a very, very serious evaluations, because the risk of surgery in those patients sometimes equals the risk of recurrent diverticulitis episode. For complicated diverticulitis, maybe after one episode, the operation should be considered. That's because now we know better than in the past that patients who presented with a diverticular abscess are more likely to have a recurrent diverticulitis and complicated recurrent account. We know better than in the past that after the first episode of a complication, diverticulitis, patients are higher admission rate, and they have an increased risk of having future emergent surgery. And what we know very well, compared with the past, is that the rate of recurrence of complicated diverticulitis is up to 60%, and that these patients sometimes have an INCI classifications higher than the classifications they had during the first attack. So after a complicated diverticulitis, maybe there is place for surgery. And these are, in summary, these indications. Moving to the technical aspect, how to cut the colon out. Sometimes we say that we have to remove the affected segment of the colon, and that's all. But this is a benign disease. This is not cancer. This is a benign disease that patients ask for a better quality of life after surgery. And these outcomes are strictly related to what we do in our OR every day. So we have to clarify the best surgical approach, open or laparoscopic, but I totally agree with Riccardo Escalante. Don't be creative, do what you are able to do in your OR. So where we have to cut the colon, proximally and distally. Do we have to mobilize the splenic flexure in all cases? And what is the best approach to the inferior mesenteric artery? Just really, really briefly. I think that we have enough details about the best approach, and this is the recommendation written on the last guidelines by the American Society of Colorectal Surgeons. When expertise is available, a minimally invasive approach to colectomy is to be preferred. That's because we have very good advantages by using this technique. So, about the level of the resection, we have not to remove all the diverticula, but we have to identify it very, very clearly where the colon is good, where the incision is not thickened, whether hypertrophy is absent. And so what we have to do, let me show a very short clip. What we have to do during our surgery is to accurately identify the level of the proximal transactions of the colon. And we have to mark these sites before deciding the extent of the dissection, because there is some vascular considerations we have to take into account before transect our colon. So we try to touch with our probes the colon, we look at the mesentery, and we try to find where is the last or the more distant diverticula, because we cannot include the diverticula in our anastomosis. At the same time, the distal transaction is a very another important point, because you know that if we include the sigmoid colon in our anastomosis, maybe the functional outcome will be worse. So what we have to do again during our surgery is to identify the colorectal junction, the sigmoid rectal junction. And then we have to mark the site to make a tattoo, and this is the distal part of our dissection. So we know at the beginning the proximal level of transections and the distal level of our transections. And it depends on the status of our colon, on the diverticular distributions, and even we have to consider sometimes the descending colon is included in the diverticular attacks, and it's the site where recurrent diverticular attacks occurs. I'm going to my conclusions rapidly. Splenic fracture, okay, it's not mandatory during our oncologic surgery, especially for rectal cancer located distally. We have to mobilize splenic fracture because no tension is one of the most important prerequisites for preventions of an anastomotic leak. But you know, we don't know how long is the colon we are going to remove. So I think that if a surgeon is fully skilled in the laparoscopic approach, maybe this step of our procedure is not, it doesn't take too much time. So sometimes I think that it could be to have the longest length it's possible, because in this case we can approach all the situation. Vascular approach, two possibilities, high ligations and low ligations. It means that in case of cancer, we have to ligate our vessel, the inferior mesenteric artery, at its origins. But when we are in the benign disease, it's not necessary. So we can ligate the vessel more proximally to the colonic wall, because in this way we can spare all the mesentery, because the mesentery includes also nerves, and maybe these nerves play a crucial role in the functional outcomes of our surgery. So what we believe is that you can see on the right the inferior mesenteric artery sections, and on the left the contrary in your screen, the inferior mesenteric artery preservations. What we do is that in the first case we are going to cut also the fibers coming from the inferior mesenteric plexus and the nerves from hypogastric plexus, and maybe this can impact on the postoperative functions of our colon. So it's not necessary. So please leave the inferior mesenteric artery trunk at its site. And this is what we usually do. Can you go on with the video, please? Just because it's the... Volevo andare un po' avanti. Ok, more? Ancora di più? Ancora di più poco? Okay. This is what we do. We identify the sigmoid vessels. And we identify this vessel, we can isolate this, because laparoscopic surgery comes along with these energy devices, very, very useful to cut and to seal. So we have this device that helps us to perform a safe surgery. We can isolate this vessel, this proximally to the colon, and in this way we can leave behind all the mesentery that contain all the fibers of the nerves I'm just talking about. So in this way, then we can clip, we can seal use radio frequency the way we want, but this is the way to go. This is a very nice dissection, and this way we can preserve what do not deserve to be removed. And this is my last slide. Riccardo Escalante showed you before. This is what we can do to prevent complications. Now we can assess the perfusions of the remnant colon and the remnant rectum by using the ICG. This is a very nice way to assess the perfusions of the wall. Maybe our anastomotic leak rate won't be 0 in the future, but this is the way to go to reduce this anastomotic leak, because I remember this is an elective surgery for a benign disease. Complications are not accepted by our patients, even in case of more serious disease. These complications are absolutely very, very less accepted in case of benign disease. Thank you very much for your attention.
Thank you very much, Dr. Persiani, for a great presentation. I will ask you a few surgical questions at the end of the session. And now we have the honor of giving the floor to Dr. Chavez de Oliveira from Brazil, who's going to talk to us about diverticular complications. All surgeons are fearful of those complications, and I will be very interested to hear his views on his management. Thank you.
I thank the organizing committee for this kind invitation. I have no disclosure for this presentation. Management of diverticulitis depends on the presentation. The most important distinction is to first determine if the patient has complicated or uncomplicated diverticulitis. Patients after a crisis of diverticulitis may evolve with some complications. Those complications more common are abscess, fistula, obstruction, and free perforation. Approximately 25% of patients with diverticulitis develop complicated disease, as abscess, fistula, obstruction, or free perforation, with a higher overall morbidity and mortality. In detail, these complications are abdominal or pelvic abscess, stenosis, and fistula, colovesical, colovaginal, colocutaneous, colenteric, and colureteral abscess. We first address the abscess here. Why is it so important to initiate the treatment as soon as possible in complicated patients? This study analyzes almost 1 million patients discharged with a principal diagnosis of diverticulitis in the US. They analyzed patients in a situation of elective treatment, urgent, and emergent treatment. They found that 10.7% had abscess, 1% perforation, and more than 1,000% died in the period of admission. And with increasing annual death rate, decreased over this period of study from 1.7% in 1988 to 0.4% in 2015. They divided patients in 4 groups: no abscess, abscess, no perforation, and perforation. All parameters were different in those groups, concerning to sepsis, hemorrhage, wound disruption, length of stay, and diet during hospitalization. And they could find that the time of initiation of the therapeutic process is very important. This study introduces the concept that the provision of urgent and/or emergent surgery has its own timeline, and that there may be an optimal time during an admission in which a procedure should be done. The complication rate for abscess was 16.4% and mortality 1.5%. And they concluded that 31% of increase in mortality for each day that the procedure was delayed. This study analyzed the outcomes after treatment of the diverticular abscess. They divided patients according to the size of the abscess less than 4 centimeters, abscess between 4 and 6 centimeters, and abscess larger than 6 centimeters. And they started antibiotics or drainage in those patients. Patients with a small abscess less than 2 centimeters did not require surgery, and patients with abscess larger than 8 centimeters almost half needed surgery. They could observe that there was no difference in the evolution in patients treated with antibiotics or drainage with abscess larger than 4 centimeters. They concluded that percutaneous drainage combined with antibiotics is not superior to antibiotics only in terms of treatment failure, recurrence of diverticulitis, or incidence of elective sigmoid resections, regardless the abscess size. Unless emergency surgery is needed, antibiotics could be considered as the primary treatment. Percutaneous drainage is an invasive procedure and does not seem to improve treatment results. Therefore, drainage should be considered when it is technically feasible and antibiotics treatment does not improve patients. This study addressed trying to find a predictive factor in CT image in those patients with uncomplicated disease that evolved to complicated diverticulitis. Those patients were from the Diabolo trial, and there was 16 patients with abscess, perforation, and bowel obstruction. They find that fluid collections and longer inflamed colon segment could influence the evolution of patients. So fluid collections and a longer inflamed colon segment on initial CT imaging of a patient diagnosed with uncomplicated diverticulitis may aid in the selection of patients not suitable for outpatient treatment and treatment without antibiotics. What are the outcomes in those patients submitted to percutaneous abscess drainage? This study included 165 patients. Most of patients had a pelvic abscess, and the abscess had a size of 6.1 centimeters, and most of them had only one abscess. Those patients submitted percutaneous drainage, most of them had improved status. The 5-year colectomy-free survival rate was 55%. And they concluded that a sizable number of patients successfully recovered from complicated diverticulitis following percutaneous drainage. Subsequent non-operative management carries an acceptable risk for recurrent episodes and may be considered as a reasonable management option. Here you can see a patient of mine with an abscess in sigmoid with air liquid level. After 7 days of antibiotics intravenous, the patient was discharged in a better condition. This study investigated long-term mortality, recurrence, and death related to recurrence for patients admitted with diverticulitis with abscess formation. Patients were divided in antibiotics, only drainage, and operative treatment. Most of them had antibiotics only as initial treatment. After 5-year follow-up, there was no difference between the 3 groups. Drainage had the highest recurrence rate with 23.6% and the highest mortality rate with 2.0%. Most of recurrence and recurrence-related mortality occurred within the first year after the primary admission. There is a high mortality and recurrence rate after the diverticular abscess, and survival was comparable between treatment groups, but patients treated with drainage had significantly higher risk of recurrence. What you can say about abscess treatment? Evidence-based treatment strategy for acute diverticulitis. Abscess formation due to contained perforation occurs in approximately 15 to 25% of patients. In general, large abscesses are usually defined as more than 3 to 5 centimeters in diameter. However, the definition differs between guidelines. Current guidelines recommend antibiotics therapy alone for small pericardic abscess and percutaneous drainage in addition to antibiotics for larger accessible pelvic abscess. Fistulas complicating diverticulitis are the result of a localized perforation into adjacent viscera and represent one of the rare complications of acute diverticulitis in 4 to 23% of patients hospitalized with diverticular disease. Diverticular disease is the main cause of intra-abdominal fistula or viscera fistula, followed by colorectal or blood cancer and inflammatory bowel disease. Concerning symptoms, most patients complain pneumaturia, fecaluria, urgency, suprapubic pain, recurrent urinary tract infections, and hematuria. Over 75% of patients describe pathognomonic features of pneumaturia, fecaluria, and recurrent UTI due to Escherichia coli and coliform bacteria. The hallmark of intravesical fistula is the Governor syndrome, characterized by suprapubic pain, frequency, dysuria, and tenesmus. The physical signs found are malodorous urine, debris in the urine, fever, and symptoms of underlying disease causing the fistula may be present. We have different diagnostic methods, old ones like poppy seed test and Burney test, and modern ones like CT and MRI imaging. Here, as a curiosity, the Burney test. The Burney test consists of a radiography of centrifuged urine samples obtained immediately after a non-diagnostic barium enema. You can see here the assay tubes with the contrast. The barium enema was the most used method to diagnose patients with suspicious colovesical or colovaginal fistula. The average detection rate of fistula is very low. Here you can see also an old technique, the POPSI test, with more than 90% of sensitivity. Today, the most used method for diagnosis is the MRI because you can study also the tract of the fistula. But remember that the POPSI test has the highest sensitivity. Here, a patient of mine with diverticular disease that underwent a barium enema with that contrast, the bladder. Here you can see this ball here, it's the bladder, very beautiful image. A simple plain abdominal X-ray may be useful sometimes when the patient is standing, may show an air fluid level within the bladder. And also, the barium enema diagnostic has low sensitivity, but it may be useful to differentiate between diverticular disease and a suspicion of cancer, colon cancer. Here now the patient with a CT diagnostic of a colovesical, you can see here air fluid level and underlying disease, the diverticulitis. Here a patient with colovesical with an MRI exam, we can see the fistula, feces, and air here in this region, and the bladder and the vagina. Here we can see the fistula and the vagina, so we can have a very good imaging of the disease. About treatment, the treatment of enterocolovesical fistulas is eminently surgical. After abdominal fistula-related sepsis has been resolved with a broad-spectrum antibiotics and a bladder decompression with a Foley catheter, the closure of the fistula have to be done. The non-operative treatment is reserved for those patients that are unfit for surgery with low symptoms or declined surgical indication. A resection may be in 1 stage, 2 stage, or a palliative procedure. The surgery may be done with open surgery or laparoscopic surgery. Here we can see the bladder, the fistula tract, and the sigmoid colon and the descended colon. Here we can see the bladder. The recurrence and the mortality rate may be high in those patients with colovesical fistula. And the last topic is the stenosis. The strictures of the sigmoid colon are a diagnostic dilemma for all surgeons. They commonly appear to diverticular disease, but carcinoma must always be excluded. Here we can see pseudotumor diverticulitis. There was a patient suspect of carcinoma by the colonoscopist. This is a study about self-expandable metal stents in obstruction for diverticulitis in the left column. Patients had moderate, minimal, or severe inflammation at the admission. And they used the stent as a permanent solution in 4 patients, as a bridge for colectomy in an elective condition in 17 patients. The placement of colorectal self-expandable stent represents a useful tool to relieve obstruction in patients with left-side colonic diverticulitis. Metal stents placement makes it possible to transform an emergency clinical condition into an elective condition, providing the time to resolve the inflammation and infection inevitably associated to complicated diverticulitis. In summary, we can say that the first treatment for abscess is antibiotics, and if necessary, drain the patient and surgery. For patients with fistula, colovesical fistula, the surgery in 1 stage is preferable. For those patients with stenosis, if you have trained personnel, you can place any stent. If not, the surgery is needed. I thank you for the attention.
Okay, thank you. And now for some questions. In order for Escalante, there's a question from the public. Does a high volume surgical activity reduce both mortality and morbidity? What do you think? After urgent surgery, obviously, your topic. That's for Escalante. So the question is quite obvious for us. I mean, the more you operate, the better you are. It's obviously. So if you have a high volume in surgery, you need to have a learning curve, the minimum of surgery you perform within a period. And then you have to maintain what you have learned with the minimum per year. But this is for everything, even for intramuscular injection. It's always so. So it's quite obvious. And then for Professor Persiani, there's a question from me. What do you mean for recurrent diverticulitis? Because it's a topic to decide whether to operate or not. What do you think? I mean,
I think this is not a question for surgeons, but it's a question for gastroenterologists, because when I see my patients, they come from the gastroenterologist. And so my classification is strictly related to what the patient experienced and the treatment he received medically at first.
When we speak about recurrent acute diverticulitis, for me, only when they go to the hospital, they have a TC, not only symptoms.
I totally agree.
Okay.
I totally agree.
Because otherwise it's a
yes,
very...
But CT scan maybe is the, is the proof that the patients experience clear serious symptoms, and the CT scan sometimes reveal the thickening without collections or the abscess. So you are completely right, in my opinion. So.
Okay, yeah. This is what. And then another question from the public. What about the problem with the operated people that keep on having symptoms?
Yeah, this is the big problem. And that's why we know this disease very well, because we have to say what we are able to do and what we are not. So I think that in the last years, maybe in the last 10 years, the elective surgery, in my opinion, in my practice, has increased. It's because patients suffering from diverticulitis is a little bit younger than in the past. Maybe obesity is another risk factor associated with this disease. And I think that after emergent surgery, what happens sometimes is considers inevitable, but after elective surgery, consequences should be evaluated very, very, very well. I started 1 year ago to follow up very strictly my patients. I'm not able to give my personal data right now, but maybe in the next 2-3 years we will be able to do. But the impression at the moment is that a good selection is the way to go to have good outcomes. So patients suffer from recurrence even after surgery, even after surgery. Maybe I stress the technical aspect because I think that the level where you transect the colon, whether if you include sigmoid rectal junctions or not, and the vascular approach, maybe all these factors should be verified in a large studies. That's because I think that now diverticulitis is treated surgically, sometimes on demand. I do what I think it's better to do, but I do not do what it really patient deserves sometimes.
Need a standardization.
Yeah, standardization is the key for everything.
And then to compare also our results. This is why. Okay, last remarks for Professor Papagedoriadis.
I think all the three speakers gave on surgery an idea of the dilemmas we're facing. We don't have, unfortunately, guidelines that can tell us now in the same way as before as to when to operate and not to operate. A difficult issue that I face is with younger patients because diverticulitis is moving now. There's a lot of epidemiological evidence to younger ages. I have many patients who are in their 40s and even many in their 30s. So the selection of patients for elective surgery is a bigger dilemma for me because it is difficult to tell somebody who's 35 with 2 episodes of diverticulitis that there is no indication for surgery, but you will probably suffer more episodes in the future because you're only 35. So I think we need some guidance on what to do with a younger group of patients who also may be more at risk because of genetic predisposition, because we heard already in this meeting and there is literature on the genetic factors. And as with other conditions, if you suffer from it at a young age, it means that there are some genes involved. So for me, what we do with the younger patients who are statistically more at risk of recurrence because they're going to live much longer, and also they may have a genetic predisposition, and also live more active lives, is a big dilemma that the surgeons or the gastrologists need to think about and give some answer.
Yes, thank you.
Okay. Savas, you can stay there because you are the speaker of the next lecture, The Future of Diverticular Disease. Next stop, Athens. The floor is yours.
Thank you very much. Can you put my presentation up, please? Thank you. Mr. Chairman, dear friends and colleagues of the International Diverticular Association, I'm grateful for the opportunity to speak after all these distinguished speakers on the subject of the future of diverticular disease. This talk is difficult because on one hand, the future is open to speculation. On the other hand, any scientific projection has to be based on existing evidence so that it is not mere speculation. I therefore tried to identify the main areas of interest to me and hopefully to yourselves that, in my opinion, hold promise for development of new understanding, new diagnoses, and new treatments in diverticular disease. And you can see here what these areas are. It's genetics, it's pathogenesis of the condition, both in terms of anatomical changes and also in terms of inflammation. The role of bacteria, the microbiota, which is increasingly implicated in this condition. Also, the understanding of forms of this condition which were probably underrated in the past, such as chronic symptoms of diverticulitis, the role of endoscopy, colonoscopy, which again was probably underrated for a very long time until recently, with the recognition of the significance of the DECA endoscopic classification. The hot topic for surgeons is when to operate, electively that is, because we have no difficulty in decision making with emergency surgery, but selection of surgical candidates remains a difficult issue which the guidelines leave to the judgment of the surgeon. We also need to find better medical treatments without surgery, and also to discuss what is the role of surgery going to be in the future. We seem to have expansion of minimally invasive surgical techniques versus a shrinkage of the volume of surgical cases. Starting from genetics, which rightfully is in the basis of everything, there is accumulating evidence of the importance of our genes in the development of diverticulitis. It is not all diet, it is not all nurture. The Swedish twin registry study since 2012 identified an increase in the risk of twins in developing diverticulitis. That was threefold increase in dizygotic twins and sevenfold increase in monozygotic twins. The Danish registry found that even being just a sibling of someone with diverticular disease gives you a 3 times higher risk of developing the condition. 40% of the patients with recurrent diverticulitis seem to have a family history. This is a recent study in 2020. We now believe that almost half of the problem is derived from genetic predisposition. Of course, the other half is derived from environmental factors, such as diet, such as microbiota, etc. The researchers have even been able to identify which particular genes have been implicated, and you can see the most suspicious ones. Excellent work has been done in this field by the Icelandic Twin Registry and also by the UK Biobank. Any deepening of our understanding in the genetics of diverticular disease will help us to manage and prevent complications in younger patients, because there is a reason the young patients get diverticulitis, and that reason may well be genetic predisposition. It will also perhaps allow us in the future to determine which patients are more at risk of complications, those ones with a genetic element. And it can also help us to understand more the pathogenetic mechanisms. Speaking of the pathogenesis, there is so much that we still do not understand in diverticular disease. We know there are motility changes, but what is the basic science of those? What is the initial disturbance, the initial pathology that takes place? Is it a disorder of neurotransmitters? Is it a collagen disorder? Is it perhaps a disorder of sensory cells that are responsible for chronic symptoms? There is already some good, strong research on these areas, and I understand that in the future we would want to know more, and we would want to understand whether the pathological motility can give rise to development of diverticular disease even before the appearance of diverticular. perhaps we would be able to interfere with this process that results in colonic wall thickening. And it would also help us to understand the origin of the chronic symptoms of symptomatic uncomplicated diverticular disease and treat it better. Also, we all know that the causes of inflammation in diverticulitis remain still a bit of a mystery. We know that it's not just infectious causes such as bacteria. We know that there are some obscure cases where acute diverticulitis can happen recurrently and severely, or in other cases, it may linger on in the form of smoldering diverticulitis or persisting diverticulitis. We also know that in a small group of cases, you have severe mucosal inflammation, you have the diverticular colitis or segmental colitis. We already face that inflammation with mesalazine, and there's also a great study by my friends Antonio Tursi and Giovanni Brandimarde on the role of budesonide. So perhaps some forms of this condition could end up being treated a bit like inflammatory bowel disease. But of course, this cannot apply to all the forms of diverticulitis. And how do these data on inflammation we have fit with the data that we have on the changes on microbiota? And what exactly the role of antibiotics is going to be eventually? With regards to microbiota, there is gradual accumulation of evidence that diverticulitis is associated with alterations in gut microbiota. We don't know why that is. Microbiota is an area where we all still learn in all specialties, actually, and not just in the gut pathology. Are they affected by diet? It seems yes. Are they affected by antibiotics? Definitely yes. Are they affected by other medications? Yes, again. But we still need to understand so much more, particularly because there are studies that show that, firstly, there is a profile probiotic of microbiota that may fit with diverticulitis, and also because trials of treatment with probiotics have given promising results, and you can see on the screen some of these trials. We need, therefore, to understand better the role of the several bacterial populations in the development of the pathogenetic process of diverticulitis. We also need some standardization of investigating this microbiota and also of interpreting the results. It's not enough to find out that this patient has a greater abundance of bifidobacterium or Acinetobacter or whatever it is. We must understand what is the association with the symptoms and whether we need to intervene. And after our intervention, apart from clinical symptoms and questionnaires, we must identify molecular markers that will help us prove our therapeutic impact. This, I believe, is going to be an exciting area of future research in diverticular disease. Patients with chronic symptoms have often been underestimated. Doctors, and particularly surgeons, are interested only in the patients who have acute abdominal pain, raised CRP, raised white cell counts, raised calprotectin, inflammatory signs on the CT scan or the ultrasound. If they don't, then they're told, well, it's not diverticulitis. What is it? Well, it's probably IBS. We now even have the concept of post-diverticular IBS, which of course may happen in the same way as post-infective IBS can happen with other infections. But we know now that it is a more complex issue. We know that we have the clinical entity of SUD, of symptomatic and complicated diverticular disease. We know that there are sensory alterations of the gut innervation and neurotransmitters. Some excellent work has been done there by several researchers like Robin Spiller and others. And we also know that surgeons who try to treat those patients to take their symptoms away by operating often find unpleasant surprises that the symptoms recur again. So in the future, I would hope that the gastroenterologists will manage to put some good quality basic science research together to find efficient treatments to manage chronic symptoms. Now, colonoscopy is the method of choice for investigating any condition of the colon, apart from patients with diverticular disease. This has been a paradox for many decades. Colonoscopy has been a little bit of a risk in the minds of many doctors and many gastroenterologists. So colonoscopy has been limited into a secondary role in diverticular disease for many years. We now understand that this is probably wrong. We now have this DICA classification, the wonderful work done by the DICA group that have shown that colonoscopy is very valuable in both giving a diagnosis of diverticular colitis, but also giving a prognosis of future diverticulitis. We need to expand more on the use of colonoscopy and put it as a basic tool in the assessment of the patients and in the decision-making of their management. Also, we heard in our meeting the fantastic work done at King's College Hospital by my friend Amin Haji, who's a pioneer in endoscopic clipping of diverticular. This is an exciting field of research. For the first time, we can select and treat certain patients with elimination of the diverticular and the symptoms. I expect a lot in this area, and I will be anticipating any future research results. Also, since we started doing colonoscopies, we started taking more biopsies, and these biopsies, I believe, will have to be studied, and there might be very interesting data that will come out of these in the future. Will we find that there are types of microscopic colitis and latent inflammatory changes that are too subtle to produce systematic inflammatory markers? Will we be able to identify more inflammatory markers like calprotectin by studying the histology of the bowel during diverticulitis? This is again an area of future research that I will find very exciting. With regards to surgical treatment, since I'm a surgeon, I have to say that surgery is shrinking in terms of volumes. We do not want to operate on many patients anymore. We try to treat conservatively the majority of them, but still, there's an important number and group of patients that have to have surgery. Now, when to operate and when not to operate, a good surgeon knows both those answers to those questions. The current guidelines, American, British, international, even our own International Diverticular Association guidelines, request that the surgeon individualizes the decision according to patient. This is an advice that is very appropriate for a number of reasons. It is also very unhelpful advice to the surgeon and can be confusing to the patient. We do need to understand more and be able to define better criteria for surgery that can be applicable by the average general surgeons in an average hospital. Because not every surgeon can be a specialist in diverticular disease, and not every hospital can have a specialist diverticular center. So the surgeons need to do more research in the patient risk profile to assess better the severity of complications as an index for surgery, to determine whether the genetic factors come into the selection criteria for surgery. But of course, all this has to be judged against the patient comorbidities and operative risk. So all these things have to go into surgical algorithms to help us with choosing patients. With regards to surgical techniques, there has been a debate in the last 20 years as to between open and laparoscopic surgery. This debate has been surpassed now completely. All modern colorectal surgeons are trained in laparoscopy, and they do laparoscopic surgery in various forms, either laparoscopically assisted or single port assisted or robotic surgery and so on. Minimally invasive techniques for surgery are here to stay, and it's exactly the same for diverticulitis. So these techniques will be applied generally in almost all hospitals, and they provide a number of advantages that have been explained by previous speakers in this meeting. We need to do more research. That needs more publicity, more money, more research funds. This group, the International Diverticular Association, is a great group. This is dedicated for this task. And I urge all of you to be fanatic subscribers, to follow us on Twitter and on LinkedIn, and help spreading this group's interests and tasks. Please subscribe to our Twitter and LinkedIn accounts and spread the publicity so that we attract the attention of the media and the attention of the fund-providing bodies for life-saving research on diverticular disease. And on concluding this fantastic meeting, I have to invite you all, arrivederci ad Atene, to see you in a year and a half's time, 20th April 2023, hopefully without any coronavirus any longer in Europe, to attend in Athens in the spring under the Acropolis, the 5th International Conference on Diverticular Disease. Thank you very much.
Thank you, Savas, for this nice presentation. And I think that now is the time to close this fourth symposium on diverticular disease. I hope that we have some answer to our question, but as told yesterday a speaker, if more answer we have, a more question will born. Is a difficult, I think, disease, and we have to know more about this disease on all the fields of this disease. So I see Ennio Oliveira. Good morning, Ennio. We are concluding the Congress, and I want to conclude to remember you that we are building this IDA society, international society, and we need that you help us to grow and to improve this society. So thank you to the speaker, to all the colleagues that was with us, that were with us during these 2 interesting days. Okay, ciao a tutti. We will see in Athens.
Thank you.